Good afternoon, friends. Greetings from CSI 2018. Today I have the honor of hosting a very famous interventional cardiologist who is our own. From India, he went to America, and there he did intervention cardiology and spread all over the USA, developing many new techniques. And I had the honor of visiting him in Alabama when he was pioneer in developing carotid interventions. And welcome, Professor Sriram Iyer. He is the director of interventional cardiology at Lenox Hospital, New York. And welcome. And how do you feel when you come back to Bombay?
Sanjay, thank you very much. Coming to Mumbai is always a very special feeling. This is the city where I was born, where I grew up. I went to medical school. So it's always very pleasant thoughts, very pleasant memories to come back to this city. And of course, connecting with all of you, the cadre of friends and colleagues that I've built over the years, all that is very special.
So he has many firsts in the field of intervention cardiology. He was a pioneer in developing carotid angioplasty way back, long way back, and developing the first implantable coronary stent also. And then he developed other techniques of peripheral vascular interventions and cardiac interventions. So he has whole plethora of, actually he is an all-rounder in interventional cardiology. So today we shall hear from him how he developed these new techniques and what were the initial challenges.
So let's start with coronary stenting. As you know, there are so many new devices, so many new techniques, but it is clear to all of us in the field that the one device, the one technology that truly made a difference to interventional cardiologists and their patients is the introduction of the coronary stent. And I had the good fortune of working with my good friend and mentor and colleague, Professor Gary Rubin, and together we introduced the first bare metal coronary stent, the Giantorco Rubin stent, in the United States in 1993. People think that the Palma-Schat stent was the first stent that was approved. That's not true. The Giantorco Rubin stent was the first one that was approved, and it totally changed the way we performed intervention. Till that time, we used to do a balloon angioplasty and we used to wonder, my goodness, is this artery going to recoil and close, and acute closure with its disastrous consequences. All of that totally changed with the introduction of that very first stent. And then of course, in subsequent years, the stent designs changed, the struts became thinner, etc. But the fundamental concept of our ability to percutaneously protect the area that you had just balloon angioplasty, that was truly a revolutionary moment. And in my own career, I would count that as one of the finest hours in intervention.
Yeah, great. See, you had the ability to challenge the vascular interventions also, vascular surgeons, and particularly in the area of the carotid interventions. How did that idea came to your mind to start the carotid interventions where the surgeons were well established doing carotid endarterectomy?
So I should give that credit also to my teacher at that time, very well known to many of you in India, Professor Jerry Doros. He was an interventional cardiologist and vascular medicine specialist practicing in Milwaukee, Wisconsin. He was the third US practitioner to do or perform coronary angioplasty in the late 70s, early 80s. But it was his vision that if we can take the same techniques and the tools that we had, and those were rudimentary tools at that time, we are talking about late 80s, and extend them for performing interventions both in the peripheral vascular as well as in the carotid field, maybe we can now provide our patients with additional options rather than simply relying on surgery. And that is how the first carotid intervention took place in 1989. I was a fellow in the program. We simply had only balloon angioplasty to work with. We did not have the right wires. Of course, there were no stents or filters. But it established one important fact, that in a fully conscious patient, you could place a balloon in the carotid artery, common carotid as well as internal carotid, and if you were careful enough, you could open up a flow-limiting stenosis, and at that time we considered that as an acceptable good result. So this is how the first carotid intervention was performed. We performed about 20 or 22 such cases, but when we went to publish them, the editors of the journals were not willing to accept it for publication, citing reasons of ethical concerns. I mean, how could you do an intervention which has its known complications, acute closure, distal embolization, even though we had extremely good results given the kind of technology that we possessed at that time, but it set the stage, at least for me, to develop additional devices that would in years later make carotid stenting safer, and that's what paved the way for the development of the distal embolic protection filter and of course dedicated stents for use in the carotid circulation.
Yes. I also had the good fortune of visiting Jerry Doros in Milwaukee, and he was doing intervention all over, and particularly he became interested in the stent grafts in AAAs and was doing renal interventions from the brachial approach and the radial approaches, and particularly the carotid interventions also he had started by that time. So a fantastic new area to explore. How did the management of carotid artery stenosis, particularly in asymptomatic patients, what are the results of the trials in asymptomatic patient, medical management versus the surgical versus the intervention?
So asymptomatic carotid artery disease in general is a benign condition. And this is the reason why there is this huge controversy. Should we be treating asymptomatic carotid disease with anything other than simply medical management? And why is that? That's because with good medical management, the risk of experiencing a stroke per year is probably somewhere in the region of 1 to 2%, maybe smaller. But in order to achieve that, you need to make sure that the patients comply with the treatment that you have prescribed them. So in other words, they need to be very diligent and compliant in taking dual antiplatelet treatment. Statins, typically in the range of at least 40 milligrams of atorvastatin. Some people will say do it more because this is no longer simply lowering cholesterol, but it's also for the view of plaque stabilization. So now, within the context of a trial, all of this is possible. But the question we need to ask ourselves is how applicable is something like this to the general population? So let me give you an example. If you tell a patient, you must take this tablet of Tylenol today because you are having a fever right now and your fever will come down if you take this Tylenol, no question the patient will take it. But if you tell them, please take this Tylenol today so that you won't get a fever next week, half of them will probably say, oh, I'll take my chances, I don't want to do this. So that's the same issues that we face between symptomatic and asymptomatic carotid disease. With symptomatic, the patient has already experienced the threat related to the carotid stenosis, whether it's in the form of a TIA, amaurosis fugax, minor stroke. So his ability to respond to a treatment suggestion is very different than the asymptomatic patient who is walking into your office, knows nothing about the carotid stenosis, and he or she is leaving your office saying, now I got to take aspirin, another antiplatelet agent, high dose of statins, you're giving me a life-threatening diagnosis, and many of them are quietly confused and stunned.
Will your suggestions to the patient differ on the degree of stenosis, severity of the stenosis, presence of other cardiovascular morbidities like coronary artery disease, or?
Absolutely. So one way to think about asymptomatic carotid disease is as follows. If you accept that about 25 to 30% of strokes, ischemic strokes, are caused by or related to bifurcation, extracranial bifurcation carotid artery stenosis, then everyone who has had a stroke on Monday morning within this category was asymptomatic on Sunday night.
Yes.
So the question is, how do we identify within the population of asymptomatic patient, the patient who's most likely going to experience a stroke or a neurological event? Unfortunately, although we have got many clues, many markers, and like you correctly pointed out, does he have other indications of atherosclerotic disease? Does he have coronary disease? Is he diabetic? Is he a smoker? Could we look at the plaque with IVUS and identify high-risk features in the plaque? Could we look at transcranial Doppler flows? What about if you do an MRI or a CT and identify small lacunar infarcts ipsilateral to the stenosis? So all of this has been tried, all of this has been explored, but when it comes down to the practical utility, we come down to basically two metrics. One is, how severe is the stenosis? With the intuitive belief that 70% is not as bad as 80, 80 is not as bad as 90, and therein lies the recommendation to the patient that if you have a high-grade stenosis, even if you are asymptomatic, you should likely consider an intervention other than medication.
Does the chances of stroke vary with the severity of stenosis?
So it is not completely clear in the asymptomatic population whether escalating the degree of stenosis proportionately increases the risk of stroke. But having said that, when we look at the landmark trials in the early 90s, the ACAS trial, which compared medical treatment to surgery, many of these high-grade stenosis were not even included in the trial.
Yes.
So we don't really know what was the risk of stroke in the medically treated arm. Those trials are being done right now. For instance, in CREST-2, there is an arm, there's a medical treated arm, where very high-grade asymptomatic stenosis will be treated with modern medical treatment to answer this question. The other metric that we use for asymptomatic patients, Sanjay, is the rapidity of progression. So let's say a year ago the patient has come to you and the velocity, peak systolic velocity was 250, the end diastolic velocity was 70, and now a year later the peak systolic velocity is 350 and the end diastolic velocity is 100. Even though the patient is asymptomatic, I consider that patient high risk for an event and very likely would say you should strongly consider treatment other than medical treatment.
Good. Thank you. So now what are the current indications for carotid stenting angioplasty in the era of the new trials where you are competing with carotid endarterectomy again?
So let's think about what medical treatment means. So medical treatment today, we understand, yes, we have got very good antiplatelet regimen, we got very good statins, but here the problem is as follows. One is, it depends upon the patient being compliant and taking these medications every day for the rest of his or her life. So Therein comes the issue of toleration, tolerance, side effects, cost, all of which will feed into the compliance. The other thing that we need to keep in mind is carotid artery disease, like any other atherosclerotic disease, is a problem of the elderly patient. And we know from cardiology that as the patient grows older, the risk and the prevalence of atrial fibrillation concomitantly increases. Some people have put, using population statistic, that it may be probably 20 to 25% of the patients older than 70 or 75. So now let's play this out. Here you have got an asymptomatic patient that you are treating with 2 antiplatelets, statins, nicely controlled. He's 75 years old and now gets atrial fibrillation, and because of a high CHAD score, the patient will need anticoagulation. So now what are you going to do? Are you going to say, I'm going to now give this patient triple therapy and increase the risk of bleeding? Or are you going to say, no, you need anticoagulation, forget about your antiplatelets? So these are real practical issues, practical problems of committing patients to very long-term medical treatment. But I am with you. I think that the vast majority of patients can be and should be treated with medications, at least for now. Let's see what the results of CREST-2 show, which is a head-to-head comparison.
Coming on to symptomatic patients, in the current era, 2018-19, what would be your indication for carotid endarterectomy and what would be your indication for carotid stenting?
So, unlike asymptomatic patients, every symptomatic patient with a connected extracranial carotid artery disease deserves to be treated. Now, if we look at the question, should the patient have endarterectomy or should the patient have stenting, that question is best answered by the result of the CREST trial. As you know, CREST was the largest prospective randomized trial done in North America. More than 1,000 patients were symptomatic, and it compared endarterectomy to stenting with distal embolic protection. And what that result of the CREST trial showed, then we looked at the composite of mortality, major stroke, minor stroke, and myocardial infarction. There was absolutely no difference between the two. True, there was a small increase in minor strokes in the carotid angioplasty stenting arm, but that was counterbalanced by a small increase of myocardial infarction in the endarterectomy arm. So today, if you ask me, how do I select stenting versus endarterectomy? It all relates to the anatomy. So if the anatomy of the carotid artery is such that I can place a embolic protection device and a stent with the expected peri-procedural risk of 6% or less, I would proceed with stenting. And the contraindications are marked tortuosity of the carotid, a hostile arch, which means an extended arch, what we call a type 3 or sometimes type 2, obvious filling defects in the internal carotid artery, and heavy circumferential calcification. Besides, of course, very marked tortuosity of the internal carotid artery, cephalad to the stenosis. So these are some of the high-risk features for stenting. If you stay away from these, I think the others can be treated with a very low peri-procedural risk. It will be well below the 6% threshold accepted by the American Heart Association for symptomatic patients.
So what are the current protection devices that you use for carotid stenting?
So we have been, at least our centers, been historically biased towards using distal embolic protection devices, and those are the filters. And the particular filter that we like is a filter that wherein the filtration element moves independent of the wire. It's called the NAV6 filter. And the advantage of it is that it makes the technical placement of the filter much easier than the other filters, which I have got the filtration element and the distal wire combined as one unit. So this is our preference to use distal embolic filtration devices. There are many centers, especially in Europe, some in the US, which will use proximal embolic protection, also with what we call flow reversal. There's a new device that combines both parts of percutaneous as well as surgical, called the T-CAR technique. So all of these are there, but suffice it to say that you need to have embolic protection when you are performing carotid angioplasty and stenting.
In every patient.
In every patient.
Except for Takayasu's arteritis.
Yes. Takayasu's arteritis is something that is unique to this part and this region of the world. And unfortunately or fortunately, we do not have any experience even close to what all of you have. So that is a completely different, what I am talking about, atherosclerotic disease with friable, potentially friable plaque with release of distal embolic debris.
See, moving away from academics, see, the cardiologists are stressed. They're working in such an environment, putting wires and balloons and stents in the coronaries and carotids. How do you relieve your stress?
Well, good question. I think over time, one of the ways, I would answer it in two ways. One is in the academic area, I think over time it has come with a temperance of the belief that everything can be treated with endovascular or everything can be treated with surgery. It is the realization that there is a healthy mix for your patient and you don't have to really stretch your technical skills or your patience or your endurance to deliver the treatment product.
Yeah.
And on the other hand, I think it's a support of an extraordinarily loving family that I have, and I'm fortunate. My wife and 3 children who have been extremely patient, extremely understanding, and I think that is the mix that basically has allowed me to perform at the level that I have and the amount of travel that I do.
Wonderful. Thank you, Professor Iyer. Thank you.
Sanjay, it has been a pleasure. It's always a pleasure to meet with you and work with you. And thank you for the opportunity to talk to
We look forward to many of your visits and many new innovations in future. Thank you.
It's been a
Thanks.
pleasure.